Now what we need to talk about is what happens once we bring that air in, what happens once it gets inside of our nasal cavity and then goes to our oral cavity and our pharynx, which is basically the back of our throat, our larynx, which comprises of the voice box, down through our trachea, bifurcates to our bronchi, continues to split off into further smaller bronchi and then bronchioles, and then ultimately to our alveoli for gas exchange. So we're going to take a quick look in this video at the process starting at the nose or nares and moving down to the alveoli. So we've taken that first breath in, we've inspired that first bit of air. What do we have? Well, we take that air into our nares, which is our nostrils or our nose, and we inspire that air. Now, we know that we have what's called vibrissae, which are basically nose hairs. And this vibrissae is that first line of defense to protect the inside of our respiratory cavities from the external atmosphere. So vibrissae are those nose hairs. Now, as we get in, we end up hitting the nasal cavity. Now, the nasal cavity has some very important anatomical structures or features associated with it, which impart very important physiological properties. So, first thing is that if you to have a look and feel that nasal cavity, this is further than bringing your finger inside your nose. This is still in your nostrils as you do this. You need to go back inside your nasal cavity. You'll find a couple of things. One, it's quite moist. That's the first thing. And two, there are these very fine hairs called cilia that line your nasal cavity. Now, the tissue, which is going to be epithelial tissue, because we know epithelial tissue lines cavities, okay? The epithelia that lines our nasal cavity is what's called pseudostratified ciliated epithelium. So pseudostratified. When we look at epithelium, we break it down according to its structure, and that structure tells you something about its function. So for example, if you have one layer of epithelial cells, okay, that's a simple layer, that's what we call it. If you have many layers of epithelial cells packed on top of each other, it's called stratified. If you have a single layer of epithelial cells but actually looks like many layers, that's called pseudostratified. So we have pseudostratified epithelia inside our nasal cavity. I also said that it was ciliated. Now these are even finer hairs than that vibrissae within our nose. And this cilia again captures particles. The other important point about this olfactory epithelia, or the nasal cavity epithelia I should say, olfactory epithelia is a bit further up. This nasal cavity epithelia is that it is highly vascularized. So there's a lot of blood vessels, and just underneath this epithelia, we have what's called goblet cells. Now these are cells that secrete mucus. So we've got ciliated mucosa that's releasing all this mucus, and it's highly vascularized. So you need to remember that, because as you bring that air in, the cilia and the mucus capture any particulates or particles or pollutants that should not be in the nasal cavity, okay? Furthermore, should not get all the way down into the alveoli, because that is quite dangerous. That's the first thing. Second thing is, you can see I've drawn these weird structures here in the nasal cavity. These structures are important. They're the conchi and meatuses, very strange names. Conchi is the bump out that you'll see, and then meatuses are the groove in. So they actually look bump out, groove in, bump out, groove in, bump out, groove in. Like I said, bump out are the conchi and the meatuses are the groove in. And what this creates is something called turbinates. So they're also known as the turbinates of the nasal cavity. And when you inspire air, as the air comes in through your nostrils, it will hit these scroll-like structures and the air will start to spin, hence the turbination. So the air starts to spin around and becomes turbulent within the nasal cavity. Why do we want this to happen? Well, as that air comes in, the more air that spins around, the increased likelihood that that air will touch that olfactory mucosa. That means the more likely filtration will occur. So particles or particulates are going to stick to that mucosa, and the cilia are able to grab it and throw it. Now, where do the cilia throw these particles? Well, it can throw it out through the nostril, or it can throw it to the back of the throat for us to swallow. And we actually swallow quite a fair bit of this particulate-laden mucus every single day, okay? So that's one thing, is that these turbinates increase filtration. What else? Well, I told you that our nasal cavity is highly vascularized, so there's a lot of blood vessels there, and this is important because it warms up all that air that's coming in, which means it doesn't matter if it's -2 degrees outside, as you bring that cold air in, it touching all this vascularized tissue will heat it up, because as that air gets down to the lungs, ultimately, we want it to be 37 degrees. So it filters the air. This is what this mucosa does. Filters the air, heats up the air, and it does one more thing. It humidifies the air. So that means it starts to attach all these water molecules, starts to make that air quite moist. And again, that's important for when that air makes it down to the lungs for appropriate gas exchange to occur. So these are some important properties of the nasal cavity. Now there's some other things that you can see associated with the nasal cavity, such as these little holes here. Now these are called sinuses. Now what we have up here is actually the cranial cavity. That's where the brain sits. And you can see the spinal cord would sit within here, and you've got the vertebrae either side. So you've got the bodies of the vertebrae and you've got the spinous processes of the vertebrae here. So this isn't part of the respiratory system, obviously. It's just for perspective. So these two areas here are called sinuses, and they're hollowed out areas of bone within our skull. Now, these sinuses are also covered with this epithelium, okay, with this mucosa. So it's vascularized, but not as vascularized as the nasal cavity. But again, it has mucus cells and cilia and so forth. There's little areas of conduction so that the air can get in and that air can get out. Now, why do we have these sinuses? Well, it's a contentious point. We don't necessarily know exactly why, but we do know that these sinuses help for resonation. Okay, so when it comes to vocalizing or vocalization, they help for resonating sound. That's one point. The second point is that if you've got numerous holes in this very thick skull, it will lighten the skull. So it makes our head a lot lighter for us. But obviously problems arise because this tissue, similar to the epithelium within the nasal cavity, is prone to infection. And when something's prone to infection, inflammation occurs, and inflammation always leads to excess secretion. In this case, it'll be mucus secretion, and it blocks up and it forms air pockets like vacuums. And this is what leads to those headaches, those sinus headaches that you get. Okay, so this air's come in. It's been terminated by these conchae meduses. It's touched the nasal mucosa, and it's filtered, it's warmed up, and it's humidified. A couple of other things is that what you'll find at the very top here of the nasal cavity are some holes through this bone. Okay? Now, this is called the cribriform plate, part of the ethmoid bone, and neurons project through, called olfactory neurons. Now, these olfactory neurons that project through give us that sense of smell, so that when all these particles come through, the more air that turbinates, the more likely some of those particles or chemicals that we've inhaled touch these olfactory neurons. This chemical signal gets transduced into an electrical signal, goes up to the olfactory bulb in the brain, and we make sense of some smell that has come in. This is important clinically because some people may come in and they've lost their sense of smell, and this may be because they've had some sort of knock to the head. Now, the first question wouldn't be, have you had a knock to the head? It may be, do you have some sort of nasal infection or a cold? Because we know when this happens, it reduces, or we even can sometimes lose for a short period of time, our sense of smell. A knock to the head can actually shift this cribriform plate in this ethmoid bone, and it can actually shear off those neurons that are projecting through, and hence losing that sense of smell. Okay, the air that's come in that we've just inspired is warmed up, filtered, humidified, so forth. It's going to come back through to the pharynx. Okay, now the pharynx is basically the back of the throat, and there's three parts of the pharynx. You've got the nasopharynx, you've got the oropharynx, and you've got the laryngopharynx. So nasopharynx, oropharynx, and laryngopharynx. So nasopharynx is basically the back of the throat at the nose, oropharynx is the back of the throat at the mouth, and laryngopharynx at the back of where the larynx is, basically our voice box. And we'll do a whole lecture talking about the voice box and creating sound and phonation and so forth. So these are all different parts of the pharynx, which is just basically this muscular conduction system moving all the way down. Now, as we get to the back, let's just say we've gone past the nasopharynx and going down to the oropharynx, and we know we can inspire air through the mouth. That's just the tongue there. We can inspire air through the back of the mouth, go into the oropharynx, and we start to move our way down. Now, we've got this important structure here called the epiglottis. Now, the epiglottis is this cartilaginous structure, which when we go to swallow food, the tongue moves up and back. That's part of the swallowing process called the buccal phase of swallowing. The tongue moves up and back, pushes on the uvula, which is the punching bag at the back of the throat, which blocks the nasopharynx aspect. The tongue moves back, pushes down on the epiglottis and blocks the laryngopharynx aspect and blocks the trachea, so that when we swallow food, there's only one place for it to go, and that's right to the back of the throat, down this tube here called the esophagus. And we know the esophagus leads to the stomach. But we're talking about inhaling air, and we don't necessarily want much air inhaled into our esophagus, even though inevitably that happens. The majority of our burps are actually just inspired air coming back out. So we've inspired this air, it's coming in, and we want it not to go down the esophagus because the esophagus is predominantly closed due to these esophageal sphincters. It's smooth muscle, and it's predominantly closed, and sometimes it will open. But we want this air to go down this tube that sits anterior or in front of the esophagus called the trachea. Okay, so here we're at the start of the trachea. Well, let's just say most superficial, or not superficial, most superior, I should say, to the trachea is the larynx. Now, the larynx is where our voice box sits, and there's numerous cartilage, tendons and so forth associated with the larynx, and also vocal cords as well, which have sort of drawn up the opening here, which are associated with creating sound. Now, again, this is going to be the focus of another lecture, so we're just going to pass the larynx now. As we hit the larynx, we're going to start to move down into our trachea. So what I've drawn up is the larynx here with the laryngeal prominence. Now, this is also known as our Adam's apple. Sorry, up here, the laryngeal prominence. That's the Adam's apple, which both male and females do have. It's just more prominent in males because it's known as a secondary characteristics, and hormones can start to produce that prominence more so than others. Laryngeal prominence, Adam's apple, and we go down and you can see the bulk of the trachea. This is where the air starts to move down. Now, air can be inspired or expired through this tube. One important thing that you're going to find is that this tube is surrounded or has numerous C-shaped rings associated with it that are made of cartilage. So the cartilaginous C-shaped rings all the way down. How many of them are there? Of the trachea, around about 16 to 20 cartilaginous C-shaped rings. The opening of the C-shaped ring is at the back. What's at the back as well? The esophagus. So the opening of the C-shaped ring actually articulates with the esophagus, and this is important because as you swallow food, the esophagus begins to distend. Now, some of us don't chew as well as we should and swallow like ducks, big particles of food, bringing it down, and that distends the esophagus so much that it can potentially impinge on these C-shaped rings. Imagine if they were fully closed, the food will get caught and unfortunately wouldn't be able to propagate your genetic material to the next generation. So we've evolved to have these C-shaped rings so that they can distend with the esophagus if need be. 16 to about 20 of them as we move down. Now, that's the cartilage of the esophagus. If you look inside, we've still got that pseudostratified, starting to become more columnar, cuboidal epithelium, still has cilia associated with it, and still has goblet cells secreting mucus. Now, this is important again because once we inspire more air, we will start to capture particles in this mucus, and the cilia, which has movement properties, start to push these particles captured in the mucus upwards. This is known as the mucociliary escalator. And it's important because as we inspire all this air, we start to inspire crappy material that we just don't want down in our lungs. Luckily, it's captured by the mucus and thrown up. What happens once it gets thrown up? It gets pushed right back to our esophagus and we swallow it. Why would we want to swallow it? Because in our stomach, we have very acidic chemicals. We've got hydrochloric acid there and other lysozymes and so forth, which can break all this stuff down. Okay, so we've got all this. Now, another important point clinically is that smokers, people who smoke cigarettes and so forth, inhale that smoke, it starts to destroy the cilia. So the cilia begin to die off. What does that mean? It means the particles get caught in the mucus and, because gravity sucks, pulls things downwards. Where does it go? Into the lungs. Hence the reason why smokers early in the morning tend to cough and cough and cough, trying to bring up all that crap that the cilia that they no longer have couldn't bring up. So it's down inside their lungs. Okay, as we go down the trachea, you'll see that the trachea bifurcates. This is also known as the carina, and it bifurcates at around about T4, T5. So thoracic vertebra 4, thoracic vertebra 5 is where it bifurcates or splits into two. This is now what we call the bronchi. So we've got the trachea here, and now it's split off into the right main stem bronchi, also known as the right primary bronchi, and the left main stem bronchi. Okay, so as it splits off, you can see it still has cartilage, but this cartilage isn't necessarily C-shaped anymore because there's no esophagus going behind it. So you can see it has this non-uniform pattern to it. So it splits off. Now, another clinically important point. The right main stem bronchi compared to the left main stem bronchi is a little bit different. One, it's wider in diameter, and two, it's more vertical. Why is this important? Well, it's important because sometimes children or even adults can inhale objects which they potentially shouldn't, maybe like a peanut, and it may get caught down in their respiratory system somewhere. Where do you think is the most likely place for this peanut to be lodged? It's going to be the right main stem bronchi because it's wider and more vertical. Now, splits off into two, and you can see that this splitting off into the left and right main stem bronchi, it will split off again. Now, this splitting off into secondary bronchi, okay, splits off on the right hand side 3 times. 1, 2, 3. And on the left hand side splits off 2 times. Okay, into the superior and inferior, and this is superior, middle, and inferior, and these will go to the various lobes of the lungs, which means that on the left hand side, the left lung has 2 lobes, and on the right hand side, the right lung has 3 lobes. Why is this the case? Is because you're going to find that the left lung actually has an area cut out of it. Okay, now this is called the cardiac notch. Cardiac notch tells you about the heart. This is to make room for the heart because we know the heart sits predominantly to the left-hand side within our chest. Okay, so it's that left lung is a little bit smaller or reduced because of that cardiac notch. So there's only 2 lobes. The right lung has 3 lobes. Now, this branching continues about 23 to 25 more times, like a tree branching. And as it branches, it gets smaller in diameter, these tubes. They go from bronchi, and once they hit about 1/2 mil, they turn into what's called bronchioles. So, trachea, left and main stem bronchi, secondary bronchi, and then branch about 23 more times till they're about 1/2 millimeter in diameter, and now they're bronchioles. Now, what's the difference structurally or anatomically going from trachea to bronchi all the way down to bronchioles? A couple of things. One, the cartilage reduces. Once you hit bronchioles, there's no cartilage, okay? But what does increase as you move down is smooth muscle. So here in the trachea and bronchi, we have very little to no smooth muscle. As we start to go to the smaller bronchioles, we have huge amounts of smooth muscle. Now this is important because of asthmatics, okay? Smooth muscle, as muscle, can contract, relax. It actually can alter the diameter of those airways. When somebody has an asthma attack, it can lead to constriction or contraction of that muscle that ultimately leads to constriction of those airways, which means in an asthma attack, it doesn't happen at the trachea, doesn't happen at the bronchi, happens all the way down at the smaller bronchioles, and that's where the airways start to close up, okay? So a lot of smooth muscle at the bronchioles, not much cartilage. Up at the trachea and bronchi, not much smooth muscle. a lot of cartilage. Okay. As we continue through, we also get reduced amounts of goblet cells and reduced amounts of cilia. Once we hit the bronchioles, no goblet cells, no cilia. You may be thinking then, how do we capture all those particulates? Well, luckily, in our alveoli sacs, this is where gas exchange occurs, we actually have important cells called macrophages. These are cells that eat up, big eaters actually. Macro meaning big or large, phage or phage meaning to eat. So they're big eaters and they help pick up anything that's left over. Hopefully by then there's not much that's getting past all those systems. So, as we move down, we're ultimately at the bronchioles, 0.5 millimeter in diameter, and it gets small. And there's two major types of bronchioles. There are, as we move down, let's just say we'll draw up some branching here. Okay, so what we've got here is how the bronchi turn into bronchioles. And we're going to have, let's say these are bronchi. Now these bronchi, they may be secondary or tertiary, or maybe the 10th branching or 20th branching maybe. And then we get down to 0.5 millimeter in diameter, we're going to have terminal bronchioles. And then at the very end, we have respiratory bronchioles. Okay, what's the difference? Well, terminal bronchioles are the very end of what we call the conducting pathways, meaning basically the tubes. These are just tubes carrying air all the way to the terminal bronchioles. Okay? The respiratory bronchioles tells you something important because the term respiration clinically refers to gas exchange across a membrane. Okay? It's actually ventilation, which means bringing air in and out, not respiration. Respiration is gas exchange at a membrane. So here where we have the respiratory bronchioles, this is also where we have our various alveoli and alveolar sacs. Okay? Now these alveoli are like bunches of grapes. And they're bunches of grapes like this because they increase the surface area. Why do we want to increase the surface area? If you were to unfold all of these alveoli, it'd be the size of a tennis court, okay? All inside of these pleural cavities that encase our lungs. These alveoli are there for gas exchange, so that means oxygen will jump out into the bloodstream that surrounds, so the pulmonary arterioles, or the pulmonary circulation, and the carbon dioxide will jump back in for us to breathe out. So gas can jump across them very easily. These alveolar sacs are 15 times thinner than a piece of paper, okay? So that membrane is very, very thin. So I think that will do us for going through the respiratory tract, broken up into the nasal cavity, oral cavity, pharynx, which is oropharynx, nasopharynx, laryngopharynx, then the pharynx, which houses the voice box, and then we've got the trachea, we've got the left and right main stem bronchi, which branch 23 times, ultimately into these structures called terminal bronchioles, the respiratory bronchioles, and then we hit the alveoli, which is the site of gas exchange. That's a very quick run through of the respiratory tract. So, what is Dalton's law and what is the clinical significance of Dalton's law when it comes to respiration? So Dalton's law states that in a mixture of gases, the total pressure is equivalent to the sum total of the individual gases. Now, what does that actually mean? Well, we can use a very simple, easily relatable example, such as that of us living in our atmosphere. So if you go down to the beach and you were to take a container and capture some of the air around you, you would find that the pressure of that air, probably surprisingly, is a pressure of around about 760 millimeters of mercury. So like I said, this is called atmospheric pressure at sea level. Now you've probably heard of millimeters of mercury as a measurement of pressure before when we look at blood pressure. The systolic pressure at the strongest contraction of the heart is 120 millimeters of mercury within the arterial system. And if you look at the diastolic pressure when the heart relaxes, the pressure is around about 80 millimeters of mercury. So how can the atmosphere around us be greater than that, 760? Well, because we're born into this pressure, so we don't feel this atmospheric pressure around us. And it has to do with the column of air immediately above us. Obviously, all this gas on top of us is pushing their way down due to gravity and placing some sort of pressure upon us that we don't necessarily feel. And that pressure is 760 millimeters of mercury. Now, the atmosphere, even though it is 760 millimeters of mercury, is made up of a number of individual gases. These individual gases include nitrogen, include oxygen, include carbon dioxide, and some trace gases. What are these trace gases? Well, these trace gases could be argon, could be water vapor, could be a number of different gases. Now, if we were to take a look, of the 760 millimeters of mercury worth of pressure around us, around about 78% of it is actually composed of nitrogen. Around about 21% of it is oxygen. Approximately 0.05% is carbon dioxide, and the rest is made up of the trace gases. So if we were to do the calculations to find out what the individual pressures are for each of these, well, you'd do 78% of 760 millimeters of mercury is around about 597 millimeters of mercury, and this is for nitrogen. If we look at oxygen, well, that's 21% of 760, and that equals around about 159 millimeters of mercury. And like I said, that's for oxygen. Carbon dioxide, 0.05% of 760 is approximately 0.3 millimeters of mercury. And like I said, that's for carbon dioxide. So Dalton's law states that a mixture of gases, the pressure of which is the sum total of all the individual gases, which means if we were to add these gases up, the 597 of nitrogen, the 159 of oxygen, and the 0.3 of carbon dioxide, it will approximately be equivalent to 760 millimeters of mercury. Now, why is this relevant clinically? Well, it's relevant clinically when it comes to looking at something called Henry's law. Of course, there's a number of different laws that you need to remember clinically. Henry's law states that when you look at an individual gas, or even looking at a mixture of gases, that the partial pressure, so that's what these are called. These pressures here are the partial pressure of these gases within a total gas. So while the atmospheric pressure is 760 millimeters of mercury, the partial pressure of nitrogen is 597. The partial pressure of oxygen is 159. The partial pressure of carbon dioxide is 0.3 millimeters of mercury. These are the partial pressures. And when it comes to Henry's law, it states that when it comes to these pressures of these gases dissolving into a liquid, it has to do with their individual partial pressures. And they will only dissolve into or down a concentration gradient. So what that means is if, for example, oxygen being 159 millimeters of mercury in the atmosphere, if you were to have a container, so this is now moving into Henry's law a little bit, but if you were to have a container with water and it was 159 millimeters of mercury outside the container, but only 40 millimeters of mercury in the container, this oxygen will diffuse or dissolve into this liquid down its concentration or down its pressure gradient. Even if, for example, in addition to this, the pressure outside for carbon dioxide is 0.3 and the pressure inside the liquid for carbon dioxide was 20. Does that mean that because it's lower of carbon dioxide outside and higher inside, its mixture together would balance it out? No, of course not. It means that the carbon dioxide is going to come out of that liquid. Okay? So it's talking about dissolvability has to do with the very specific partial pressure of that gas. It goes down its own pressure gradient. It doesn't care what the pressure gradient is of any other gas around it, even when it's within a mixture like this. So what is Dalton's law? Dalton's law states that when there's a mixture of inert gases, that its pressure is going to be an equivalent to the sum total of all the individual pressures. And if you know the percentage of those gases, you can easily calculate what's termed the partial pressure of those individual gases. What is Boyle's law and what is its clinical relevance when it comes to respiration? Well, first we need to define what Boyle's law is. Boyle's law states that as the volume of a container increases, the pressure within that container decreases, and vice versa. So as the volume of the container decreases, the pressure of gas within that container increases. So what that means is there's an inverse relationship between the volume of a container and the pressure of gas inside of that container. So if we were to write that down, shorthand would state that as we increase the volume of a container, it results in a decrease of gas pressure within that container. And vice versa, decrease the volume equals increase in pressure. So let's first graphically describe what that really means, and then we'll refer to what it means clinically. So if we were to draw up a container, and let's just say we were to put a piston in this container, and inside of this container, we have gas particles. Let's just say we have oxygen inside of this container. Let's just say we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20 gas particles of oxygen. 20 oxygen molecules within this container. And we were to measure the pressure inside of this container. Let's just say that the pressure is 10 kilopascals. Now don't really worry about the units here, but remember that it's 10, okay? 10 kilopascals. All right, now let's just say, so there's a particular volume of this container. All right, now let's just say that we were to push down on this syringe. Now it's a closed container. Remember, this is very important. It's a closed container. What if we're now to push down on this syringe? What would happen? So we've pushed down on the plunger. And what ends up happening is how many molecules of oxygen did we begin with? 20. We now have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20 oxygen molecules still within this container, but they now have less space to move around. So let's think about this for a second. Let's think about what pressure actually is. When we talk about blood pressure, for example, we talk about the force that the blood puts on the walls of those vessels. When we talk about pressure in this case, the pressure of gases, again, it's the force that these molecules put on the walls of its container. So here where we have a larger container, these 20 oxygen molecules, as they bounce around, they're bouncing off the walls, bouncing off each other, they are putting some sort of force on the wall of that container, and that's measured as pressure. In this case, it was 10 kilopascals of pressure, okay, as it's bouncing around. Now, think about as we decrease the volume of that container or decrease the size of that container, we still have 20 molecules bouncing around, but they have less room to move around. So does that mean statistically, is it going to be an increased likelihood of these molecules hitting walls and hitting each other, or a decreased likelihood? What's going to be an increased likelihood? So you have more of these reactions in which it bounces off the walls, bounces off each other. And what this does is it increases the pressure inside of that container, because again, pressure is going to be a measurement of the force that's generated by these molecules inside the container on the walls of that container. Okay? So this is that inverse relationship. Decrease the volume of a closed container, increase the pressure of the gas within that closed container. Now, what does this have to do with respiration and breathing? Well, let's think about if this container was open at one end. All right, let's look at the first syringe. We have gas, 20 oxygen molecules, and let's say that out in the atmosphere, we're also going to have some oxygen molecules. Now, with this syringe or plunger not moving, the amount of gas inside of that syringe compared to the amount of gas outside would end up balancing each other out, okay? Because we know that as these oxygen molecules are bouncing off the walls, there's going to be some probabilistic likelihood that it's going to bounce outside of the syringe. And the same notion, some are going to bounce into the syringe, and over time this exchange will be equivalent, and the pressure inside of that syringe will balance out with the pressure outside of that syringe if you were to just leave it and not even touch that plunger, okay? So it balances itself out. Now think about what happens when you push on that plunger. As you push down, think about it, as you push down, you're decreasing the volume and increasing the pressure, so you're increasing the amount of times that these molecules bounce off the walls and increase how many of these oxygen molecules are going to bounce out of the syringe. You're going to get an increased likelihood of oxygen molecules bouncing outside of this syringe. And what does that mean? It means that as you push down, you force air or oxygen out of the syringe into the surrounding atmosphere. Now this makes sense. If you were to get a syringe and you put your thumb on the end of it and push on the barrel of that syringe, what's going to happen is you feel that pressure pushing onto your thumb. You remove your thumb, the gas flows out. Now what that's telling you is that pressure always moves down a concentration gradient. Always moves from high pressure to low pressure. Always from high pressure to low pressure. Okay, a high pressure system is moving in, they may say when you're watching the weather. It's always going to go from a high pressure system to a low pressure system. Now what does this mean when it comes to respiration? Well, think about what we have. If we were to compare this syringe to our respiratory system, well, let's take a quick look. If I were to draw a very simplistic version where we've got our trachea coming into our lungs. Now obviously we have a left and right lung, but this is what we've got here, and we're going to have our pleural cavity, and we're going to have our ribs either side. Obviously we have more than 6 ribs, and we're going to have our diaphragm down the bottom as well. Let's colour that diaphragm in red because we know it's skeletal muscle. And we also know that our external intercostals are going to be lining the outside of our ribs here. And these are the 2 muscle groups I want to focus on first of all. Now, when you take a breath in, what's actually happening is that diaphragm contracts and moves down. Because it's this dome shape. As that diaphragm contracts and moves down, what happens is it opens up, it increases the volume of this thoracic cavity. Now remember Boyle's law, as you increase the volume, you're going to decrease the pressure. And that means the pressure inside of the lungs is going to be less than the pressure outside of the lungs. And I also told you that gas likes to go from high to low. So if the pressure in the lungs is lower than the pressure outside, what's going to happen? Gas will inevitably be dragged in to the lungs. That's how we inspire, that's how we bring this air in. Now we've also got our rib cage with our external intercostals attached, and they can also contract too. Now if they're contracting, they're going to be contracting up and out. If they contract up and out, they're going to further increase the volume of this thoracic cavity, making the pressure inside of the thoracic cavity even lower, which means there's now a greater differential of the pressure from outside to inside. So it's going to be higher outside compared to inside, and gas always goes from high to low, so more gas will rush in. So what I'm basically telling you is the more muscles we recruit to increase the thoracic volume, the more air we will inspire into our lungs. Now obviously when we relax these muscles, the volume will decrease and that air will be pushed straight back out. This is the clinical relevance of Boyle's law. So in this video, we're going to take a quick look at the muscles involved in respiration. So these are the muscles that we use to allow air to rush into our lungs and also to push that air back out of our lungs. So the muscles used for inspiration and expiration. Now before we begin, you need a basic understanding of the physiology. So just very quickly, you need to understand something called Boyle's law. Now Boyle's law simply states that the volume of a container is inversely proportional to the pressure within that container. So what I mean is this, that sounds quite confusing, but it's simple. If you have a container of a fixed volume, inside of that container there's going to be a number of gas particles. And those gas particles are going to be bouncing around at all times, as gas particles do, and they're going to be bouncing off the walls of that container. If you were to measure the pressure inside of that container, you're simply measuring the force generated by those gas particles bouncing off the walls of the container. Now, let's say we take that container and we were to squish it down. We keep the same amount of particles of gas inside, but we now halve its size. Well, what now happens is that the same amount of gas particles have less space to move around, and they're more likely to bounce off the walls, which means when you take a measurement of the pressure inside, the pressure is going to be greater because they're going to be more likely hitting off the walls at a greater force. Okay? So we've just decreased the volume and increased the pressure, hence the inverse relationship. Again, if you were to take that same container with the same amount of gas inside and you were to double its size by keeping the same amount of gas particles inside, you've now got these gas particles floating around a larger area, and there's less likelihood that those gas particles are going to bounce off the walls of that container. Therefore, the pressure will be reduced. So by increasing the volume, you're decreasing the pressure. Now this is important, and it's also important if you take this piece of information in consideration to this piece of information, that gas will always move from an area of high gas pressure to an area of low gas pressure, okay? You watch this on the news, or the weather I should say, all the time. The weatherman or woman will say that there's a high pressure system moving in. This is simply saying that high pressure gases are coming towards an area where there's low pressure gases. Now take these two pieces of information together, and what that means is this. Our lungs sit within our thoracic cavity. So here's our thoracic cavity, okay? Now, our lungs are adherent to that thoracic wall. So if we were to increase the volume of our thoracic cavity, we are effectively decreasing the pressure inside of our lungs. That means that the pressure inside the lungs is decreased or reduced compared to the external environment, and therefore gas wants to rush towards that negative pressure. So all that air will come in to our lungs through our nasal cavity, through our oral cavity, down to the lungs. If we were to decrease the volume of our thoracic cavity, we're increasing the pressure in our lungs, and air wants to rush out. So that's how we breathe in and out. And the way we do this is by contracting muscles. So let's first look at the muscles used in inspiration, breathing in. The major muscle you need to be aware of involved in inspiration is the diaphragm. Now the diaphragm is the muscle that separates the thoracic cavity from the abdominal cavity. It is basically the anatomical barrier between those two cavities. It's an unpaired skeletal muscle that's dome-shaped, okay? Now, a couple of pieces of information. In order for you to understand the diaphragm a little bit better, I've drawn up this picture. Now you may look at this picture and think this is making things worse. That's a terrible picture, but let me try and orientate you to what we're looking at. So what we've just done is we've done a transverse section through me, right at the thoracic and abdominal junction or barrier, which is right where the diaphragm is. We've cut straight through, and now we're looking up through. Using your eyes, you're looking up through to my thoracic cavity, which means what you're looking up at is my diaphragm, okay? Now, you can see that there's going to be the front and the back, anterior, posterior. That's the xiphoid or part of the sternum, and here's the ribs coming around towards the back, and then you can see some of the lumbar vertebrae telling you exactly where we're looking at, the very top of the lumbar vertebrae, L1, 2, 3, and 4. Now, a couple of points you should be aware of for the diaphragm is that you can see that the diaphragm is attached by these ligaments to the lumbar portion of our spine. This is called the crus of the diaphragm, okay? And it's attached there, so there's anchorage points. The diaphragm's also attached to the thoracic wall, which you can see here, and the sternum as well. Now, there's three major holes in the diaphragm. Okay, now two true holes, one which isn't really a hole. Let's talk about that one first. At the very back of the diaphragm, which you can see here, pretty much against our vertebrae, you've got a blood vessel that's coming down from the heart through the diaphragm down to the rest of the body. This blood vessel is called the aorta, and it's the major artery coming away from the heart that feeds the body with oxygenated blood. Now, This aorta doesn't actually go through a hole in the diaphragm, it actually goes through a gap behind the diaphragm, posterior to the diaphragm. This is important because if the aorta went through a hole in the diaphragm, it means that anytime the diaphragm contracts, it may grossly impede blood flow. And we obviously don't want that happening coming from a major arterial blood vessel. The other two holes is one here and one here. This one here is what's called our esophageal hiatus. Basically the hole that allows the esophagus to come through. This one up here is a cavity or a hiatus that allows for the vena cava to move through. So I said the aorta is the major artery coming down from the heart. The vena cava is the major vein going back to the heart. So it's actually coming back up through the diaphragm. Okay? Now the diaphragm is innervated by a nerve called the phrenic nerve, and the phrenic nerve comes from cervical regions 3, 4 and 5. So phrenic nerve comes from cervical 3 to cervical 5, and you can remember that C3, 4, 5 keeps you alive. So this is, now you may be thinking, if the diaphragm's down there, I know that C3, 4 and 5 are up here. So why is it that there's a nerve or a nerve plexus that's coming from the neck innervating the diaphragm? And that's simply because embryologically, if you've looked at the embryology lectures, the diaphragm originated up in the neck. Okay, and so it's basically pulled those nerves down. So the diaphragm, when it contracts, it's pulling on these tendons, it's pulling on all its connections to the thoracic cavity, and what it does is it pulls on this white thing here. You're probably thinking, what is this white thing that I've drawn? It's not another hole. In actual fact, this white thing is filled with collagen, and it's actually a tendon. Okay, so I've drawn all these red lines here to indicate that that's muscle, that skeletal muscle of the diaphragm. This big white part right in the middle is a tendon called the central tendon. So when the diaphragm contracts, all of this skeletal muscle pulls, and it pulls on that central tendon. And what that means is, I told you it's a dome shape. As it pulls, it flattens that central tendon down, which means it increases the thoracic volume. That decreases the pressure and air rushes in. So the diaphragm, when it contracts, is the major or main muscle for inspiration. Okay? Now, there are other muscles used in inspiration, what we call accessory muscles. And why are they called accessory muscles? Because we basically just need the diaphragm to bring air in and out when we do what's called quiet breathing. So the breathing you're doing right now, when you're sitting down, when you're relaxing, it's called quiet breathing, and you're breathing in about half a litre of air, out half a litre of air, in half a litre, out half a litre, simply by the diaphragm contracting, relaxing, contracting, relaxing. But there's other muscles called accessory muscles that allow us to do what's called forced inspiration. Breathe in more than that 500 mils of air. So let's talk about those muscles. Now, I've drawn a picture of the body, thoracic area, the external anatomy basically, and you can see some bones and some of the musculature. So let's orientate you. So these are the clavicles up here. This is the sternum coming down here. Here we've got the first 5 ribs attached to the sternum. Okay, and it's up the other side too, but hidden by this muscle, which I'll talk about in a sec. And then 6, 7, 8, 9, and 10 coming out here, and I haven't got the floating ribs or anything like that. And then we've got the red stuff are all muscles that are attached to it. So let's talk about it. Now, when you take a breath in and it's forced, if we need to bring more air in than that quiet breath and that 500 mils, we need to increase the thoracic volume even more. The more you increase the thoracic volume, the less the pressure gets inside, so the more negative it gets inside, and the more air that rushes in, which means the more muscles you recruit to increase the thoracic volume, the more air will come in, okay? So, let's talk about some of these muscles that we're going to recruit for inspiration. All right, so probably the first muscle I should state, because it also is involved in quiet inspiration, but is definitely involved in forced inspiration, is what we call the external intercostal muscles. Now, costal means cartilage, inter means between, intercostal means between cartilage. What we're referring to is the muscles that sit between the ribs. Okay? Now, external intercostals tells you that it sits more externally to another set of intercostal muscles called the internal. Now, the internal are used for forced expiration. So don't get those two too confused. So firstly, for forced inspiration, external intercostals, and you'll see that they are orientated like this. Okay? These are the external intercostals, and when they contract, they pull up the rib that's below them, okay? Which means they pull up and out the rib cage. What does that mean? If you're pulling up and out the rib cage, again, you're increasing the thoracic volume. So these are the external intercostals. External intercostals, okay? Now, next muscle is, or group of muscles, are the pectoralis muscles, so the pecs. Now you've got the pec major, pec minor. So let's have a look. What I've drawn here is obviously clavicles. Here's the deltoid, so the shoulder, and the start of the bicep, tricep here. Now that's part of the lat, so I just want to show you basically coming down here. This is the pec. This is actually pec major, the largest pec muscle, and you can see it coming in, attaching to the clavicle, attaching to the sternum, and so forth. So when the pectoralis major muscle contracts, it pulls on the sternum and ribs, and again, lifts it up. So think when you take a big deep breath in, you contract the pectoralis major muscles, and it lifts it up and out, again increasing thoracic volume. Decreasing lung pressure, air rushes in. Inspiration, okay? Now, this is innervated by the pectoralis nerve, and this is coming from around about C3 to C8, okay? Cervical 3, cervical 8, and a bit of T1, thoracic 1. And it, like I said, comes from the pectoralis nerve. These nerves also innervate pectoralis minor. Now, pectoralis minor is this muscle right here. And what you can see is pectoralis minor is coming in and is attaching to rib 3, 4, and 5, which means when you contract pectoralis minor, it's going to lift rib 3, 4, and 5, again, increasing thoracic volume. So we can then state that we've also got pec minor involved and pec major. What else is involved in forced inspiration? Well, we've also got the serratus muscles. The serratus muscles, the serratus anterior, are these muscles here that you can see look like they're attached to the ends of the rib. And again, when you contract them, they're going to shift the ribs as well, increasing thoracic volume. So these muscles here are the serratus anterior. You've got a muscle called the sternocleidomastoid muscle. Now the sternocleidomastoid muscle, sterno, sternum, cleido or cleido means clavicle, mastoid referring to the jaw. So this is a big strap-like muscle which you can see attaches to the clavicle here and to the sternum as well. Now let's write it down first. Because it's such a big word, I can't talk and write it at the same time. Sternocleidomastoid. And again, when this muscle contracts, it's going to lift everything up and out, okay? Again, increasing thoracic volume. Now, this muscle is innervated by the cranial nerve 11. I wanted to bring that up because maybe you've gone through cranial nerves already, maybe not. Cranial nerve 11, O, to touch and feel. Very good, velvet. R, heaven. Starts with A, it's the spinal accessory nerve, sometimes also known as the spinal nerve. So this nerve helps to, it's not the only nerve that innervates it, but helps to innervate the sternocleidomastoid muscle. Now another muscle that's involved is this muscle, which sort of sits next to and behind the sternocleidomastoid, which is called the scalenes. And you've got the anterior, middle, and posterior scalenes. And you can see that these scalenes are attached to the first and second ribs. Again, contracting, lifting them up, increasing thoracic volume. So these are the major muscles that are involved in, accessory muscles I should say, involved in forced inspiration. So quiet inspiration, diaphragm and external intercostals. Forced inspiration, definitely external intercostals, the pec muscles, the sternocleidomastoid, serratus anterior, and scalenes. These are the muscles involved in inspiration. Now in this video, we're going to take a quick look at the muscles involved in expiration. In the previous video, we looked at the muscles for inspiration and very quickly stated that they were the diaphragm, external intercostals, the scalenes, the serratus anterior, and the sternocleidomastoid, and the pectoralis muscles, major and minor, just to name a couple. Now in this video, let's have a look at those muscles that are involved in getting that air out of the lungs. So remember, Boyle's law states that the pressure of a container is inversely proportional to the volume of the container, which means if we need to get air out of the lungs, we need to compress that container to increase the pressure so that air goes out from a high pressure to a low pressure. So what can we do? Well, we know that when we breathe out, we compress our abdomen. And that's basically what we need to do. We need to try and reduce the volume of the thorax and compress the abdomen. And you can really have a good understanding of what muscles are involved in this when you actually do the process. Breathe out forcefully. First thing you know is your abdominals are contracting. So let's have a look at what abdominal muscles are involved. First of which, you have the rectus abdominal muscles. So here are the rectus abdominals. Now, rectus means straight, and you can see that these abdominal muscles are straight up and down. So these are the rectus abdominal muscles. In addition to the rectus, you've got the external obliques. Now the external obliques, one, external is telling you it's most superficial. Oblique means it's at an angle, okay? Now you can see the external obliques here attached to the 5th, 6th, 7th rib, and in actual fact, the external obliques are attached to the lower 8 ribs. So that's 5, 6, 7, 8, 9, 10, 11, 12. Okay, so the external obliques are attached to the lowest 8 ribs. And when you contract it, it pushes the ribs up and in. And what does that do? It compresses the abdomen, allows you to breathe out by increasing that pressure. So these are the external intercostals. The external obliques. Talking about the external intercostals, I said that they were involved. That's these ones here. I said that when they contract, they lift the rib below them, increasing your thoracic cavity. The internal intercostals, which are actually these ones here, you can see they internal intercostals, so they are deeper to the external, and you can see that they go in the opposite direction. The fiber runs in the opposite direction. When they contract, what they do is they push the rib down and in, and again, reducing thoracic volume. So these are the internal intercostals. Now going back to the oblique, we've got the external obliques, which I said lower 8 ribs that it's attached to, that's its origin site. If you go a bit deeper to the external obliques, you have the internal obliques, and you can see again the internal obliques, the fiber moves in the opposite direction, and they're actually attached to the lower 3 ribs, and you can see here the internal obliques also involved in reducing thoracic size by compressing the abdomen. Even deeper to the external obliques is the transversus abdominis muscles, and again, when they contract, compress the abdomen. Transversus abdominis. And the last one I want to talk about is this muscle coming down here, which is the latissimus dorsi, the lats. When that contracts, you can see what it does is it brings forward your thoracic cavity and again compresses that thoracic cavity, forcing you to exhale. So you can see that there are a number of other muscles involved in expiration, that's bringing air out, and their goal is when they contract, they reduce the thoracic volume and they compress the abdomen to bring it up, compressing that thoracic volume, making the pressure inside the thoracic cavity and lungs higher, and that air is forced to run out. So you can see we've got the internal intercostals, external internal obliques, transversus abdominis, and the rectus abdominis and the latissimus dorsi. These are the muscles for expiration. Hi everyone, Dr. Mike here. In this video, we're going to talk about neural regulation of breathing. This is how does the brain control our respiratory rate. So first thing you need to be aware of is the fact that we've got our lungs here and we know that we need to bring air into our lungs and back out of our lungs. And the way that we do this is because of pressure changes. Now simply put, anytime you increase the volume of a container, you decrease the pressure inside. And so for example, if I were to increase the volume of our lungs by contracting the diaphragm and pulling it down, contracting the external intercostal muscles of our rib cage and pulling it up and out, the lungs get bigger. Now because you're increasing the volume, the pressure inside gets lower. That's called Boyle's law. And when pressure is low, gas will always move from a high to a low pressure. So air rushes into the lungs. Now when we want that air or gas to go back out, we simply relax the diaphragm, it snaps back up. We relax the external intercostals, the rib cage moves back down, and the elastic recoil of the lungs snap back into place, therefore decreasing the volume, increasing the pressure inside, and gas moves back out again. So that's the basics, that's breathing mechanics. But how do we tell the muscles of the external intercostals and the muscle that's the diaphragm, how do we tell it to contract? Well, this has to come from our brain, and specifically it comes from our brain stem. Now we know our brain stem is made up of the midbrain, the pons, and the medulla, but specifically we're referring to the pons and the medulla when it comes to breathing. Now, another thing you need to be aware of is we have what we call this basal breathing rate, this normal inspiration, expiration, okay? This quiet breathing. And this actually originates at the back of the medulla, the most dorsal region of the medulla, takes up most of the medulla as well. And this is the dorsal inspiratory region. And what happens is these neurons spontaneously fire off. They don't need any signals coming from anywhere else in the body. They will spontaneously fire off. They're timed to do so. In actual fact, you can cut everything below the medulla, cut everything above the medulla, and they'll still fire off. Now, they won't be firing off to anything, but they'll still fire off. When they fire off and you've got a nice intact spinal cord, what they'll fire off to is they'll send signals down to C3, C4, C5. So these are the cervical nerves 3, 4, 5, right? At the level of the neck. And they send these signals out and they will send a signal through C3, C4, C5, and these signals go down and they innervate the diaphragm. So C3, C4, C5 keeps you alive. That's what we say because they innervate the diaphragm via a nerve called the phrenic nerve. Now, in actual fact, for quiet breathing, just breathing in, breathing out quietly, 500 milliliters in, 500 milliliters out, you only need the diaphragm to contract, which means the dorsal aspect of your medulla is firing these neurons off through C3-5, and it's doing it in a patterned way. Fire, stop, contract, relax, and that's normal, quiet breathing. But sometimes you need a little bit more air coming in, and so this dorsal region of the medulla can also send signals down to the thoracic area, that's here, through a couple of nerves, and these nerves are going to come out and they will innervate the external intercostal muscles, right? And if you innervate the external intercostal muscles, you'll tell them to contract, and if they contract, they bring the rib cage up and out, further increasing the volume, further decreasing the pressure inside, further pulling more air in, right? So it's all about, if you want more air in, you just got to increase that thoracic volume. All right, so we've spoken about these inspiratory neurons here at the medulla that spontaneously fire off, but we can also, depending on what's happening in our body, we can alter that, okay? There's actually an area above it in the pons, again, the dorsal region at the back of the pons, and this is called the pneumotaxic area. And what this does is it's like a switch, okay, like a light switch. Because these neurons in the medulla are going to constantly fire off, sometimes you need to tell them to stop. And if you tell them to stop, it shortens the breath in. So instead of, you can fire the pneumotaxic area and you go, so you can increase your respiratory rate, again, through this pneumotaxic area. And like I said, it sends these inhibitory signals to these inspiratory neurons that are spontaneously firing off. Now, Other things can happen in our body. For example, if we have increased levels of CO2, decreased levels of O2, or increased concentration of hydrogen ions in the blood, these can all trigger this inspiratory center in the medulla. And one of the ways that it can do it in the peripheral portion of our body, okay, so not centrally, not in the brain or brain stem, but it can do it peripherally at the aorta. So here's the aortic arch. So you can have the heart here, the aortic arch coming out. Here's the 3 branches, and 2 of them turn into carotids, and you're going to have chemoreceptive neurons, okay? So these are chemoreceptors. They're based at the aortic arch. They're also based in the carotids, and they will pick up concentrations of increased carbon dioxide, decreased oxygen, and increased hydrogen ion concentration, and they will send signals to this inspiratory center. Now, if they're doing it via the carotids, it's going to be through the glossopharyngeal nerve. And if it sends it via the aortic arch, it's via the vagus nerve. And like I said, it stimulates these neurons and tells you, let's breathe a little bit more. So what we've got here is the neural control of breathing. It's stimulated predominantly by increased carbon dioxide and predominantly from decreased hydrogen ions. And basically the last scenario is decreased oxygen. That's right, increased carbon dioxide mainly because we know the equation. CO2 plus H2O gives you H2CO3, carbonic acid, which hates itself, splits itself apart, turns into hydrogen ions and bicarbonate ions. But the most important thing here is CO2 turns into acid in the blood. Carbon dioxide turns to acid. We don't like acid. We die if we have too much of it. So one way of getting rid of it is breathing out. Breathe out CO2, breathe out acid. Therefore, the body is most receptive to CO2 and acid as stimulators to breathe. And that is the neural control of breathing.